will be by Paul Solak, who's professor of psychiatry at the University of Pittsburgh School of Medicine and is the Western Psychiatric Institute and Clinic. And Paul, as I mentioned before, was a major contributor to the practice guidelines project of the APA, serving as our expert for medication and psychopharm. But today he's going to talk to us about psychobiology of suicidal behavior, which is a major risk factor in patients with borderline personality disorder. So welcome, Paul Solak.
Thank you, John. Thank you. It's a pleasure to be here. Today I'm going to be spending some time reviewing with you a study that we've been doing for many years on the psychobiology of suicidal behavior and borderline personality disorder. This project is basically a longitudinal study looking for the risk factors that predict suicidal behavior in borderline patients. The project has always had both a large psychosocial component, looking at clinical, demographic, psychological, and familial characteristics of these patients, and always a small subset of biologic studies focused on the biology of impulsivity, which is a major risk factor for suicide in borderline patients. So I'll try to cover both aspects. My presentation today is somewhat of a progress report, since I had the privilege of presenting our earlier work at a previous meeting at this organization. These are some of my co-investigators over the many years. Now, suicidal behavior has been termed a behavioral specialty of the borderline patient. I particularly like this phrase. It's attributable to John Anderson, Rodolphe, because as a clinician, speaking as a clinician, this is how most of us come in contact with our borderline patients. We see them in the emergency rooms, we see them in the hospitals after a suicide attack. Well, how big is the problem? Well, if you look at epidemiologic type studies, about half of parasuicides admitted to hospitals have borderline personality disorder. Some studies of epidemiologic nature, over 1/3 of community suicides, completed suicides, have borderline personality disorder as one of the diagnoses. If you look at a clinical sample, this is our own clinical sample of sequentially interviewed borderline patients, over 70% are suicide attempters, with an average of 3.3 lifetime attempts. The current sample, as we follow these people over many, many years, are that the average borderline patient followed for years has about 4 suicide attempts. Completed suicide rate is rather high if you look at longitudinal studies. That is, anywhere from 3% to 10% of these people died of by suicide. The average age of a completed suicide victim is 37 years in the Paris and his wife Frank's. This is from Montreal, and it's a very important study, even though it was a naturalistic follow-up, because Joel Paris followed these patients for 27 years. So to get a suicide rate of 10% is a pretty important finding. Now, our study basically uses what's called the stress diagnosis model of suicide. This is a model that's been popularized and expounded upon by John Mann at Columbia, who's the foremost proponent. He's done many, many important research studies supporting this concept of suicidal behavior. And basically, the stress diagnosis model holds that suicide occurs, or suicidal behavior occurs, when an acute stressor interacts with chronic vulnerabilities. Very straightforward concept. What are the acute stressors? Well, the major risk factors that we're used to thinking of as clinicians. That is the high-risk axis 1 disorders, predominantly major depression, schizophrenia, or alcohol use disorder. In the case of borderline patients, these also can be interpersonal losses or experiences of rejection. Certainly, rejection loss experience leads to the anger kind of affect, and the impulsive behavior that results in suicidal behavior in all borderline patients. It's often said that borderline patients kill themselves more often out of anger than they do out of sadness. If those are the acute stressors, then where's the vulnerability in borderline patients? Is it the diagnosis itself? Well, certainly if you look at the epidemiologic studies where they make the categorical diagnosis, they would say that the categorical diagnosis of borderline personality disorder is one of the vulnerabilities that leads to suicidal behavior. If we look only at borderline patients, what part of the borderline syndrome, what part of that diagnosis leads to the vulnerability of suicide? What are the dimensions that are related to suicidal behavior? Now, this is a quick schematic of developmental model of borderline personality disorder. And as we've heard from Dr. Livesley before, there is a strong genetic, keep working. There's a strong genetic component to borderline personality disorder. It involves primarily impulsivity, aggression. We believe that's rooted primarily in serotonergic function. I would add serotonergic function that involves the prefrontal part of the brain. It's involved with inhibition. But we also have developmental experiences, adverse childhood experiences, especially the experiences of abuse and neglect. These appear to be the two major streams that lead to consequences that are involved in the development of borderline personality disorder. Impulsivity, aggressivity, diminished serotonergic function are commonly found in disorders in adolescence and childhood, such as alcohol use disorder, early alcohol use disorder, substance use, conduct disorder, head injuries as a consequence of some of those behaviors. If we come down to the abuse experiences, specifically looking at consequences of physical or sexual abuse, we see that post-traumatic stress disorder, even major depression is more prominent in people who have had those early adverse experiences. Brain volume loss has been found in adults who have had adverse experiences of physical and sexual abuse in childhood. I emphasize adults because the best study that is existing, that of Dr. Michael DeBellis, looking at adolescents who were sexually and physically abused, adjudicated by courts with proven abuse histories. These girls did not have the same findings we find in adult borderline patients. They did have some cortical atrophy and some volume loss in the overall cerebral cortex, but they did not have phase. Thank you.
Is it on stone?
It's sort of rouse. Thank you. Okay. So I'm entering a caveat to the common literature finding that you have volume loss, specifically in the hippocampus and amygdala, in adult borderline patients with histories of physical and sexual abuse. That hasn't been shown in adolescents who have clear-cut histories of abuse. And I offer that as a challenge to people to go and find where the adult finding comes from. In any event, these experiences, which occur in probably less than half of people who go on to have borderline personality disorder, are associated with changes in the pituitary function, as well as brain volume loss. So it's a complex picture, and what it leads to is a pattern of personality structure, which we call borderline personality disorder when it meets DSM criteria. Other fields, especially in mood disorders, are referring to it these days as a vulnerable phenotype. Now, if you start with that vulnerable phenotype, and you have additional factors, such as schizotypal traits, the occurrence of major depression and social personality disorder, or adverse recent life events, you end up with an increased frequency of suicidal behavior. So these so-called mediators become the stressors, the acute stressors, and in some cases, like antisocial personality disorder, chronic vulnerabilities that are correlated with adult suicidal behavior. There are some things, fortunately, which do moderate, which can improve the picture and diminish the frequency, the likelihood of suicidal behaviors. Psychotherapy, medication, social adjustment, especially social adjustment. that you will hear in a few minutes. So a complex model, all of these factors which are referred to as mediators, the factors that I referred to earlier, both developmental and biologic, become risk factors that you investigate in suicidal behavior in adulthood. So research for risk factors in borderline personality disorders is fairly comprehensive. It involves everything from demographic variables, diagnostic, childhood and family history, social adjustment, treatment history. Basically, an investigator tries to correlate all of these factors with suicidal behavior in adulthood and see what predicts suicidal outcome. Well, the early part of our work had to do with discriminating attempters from non-attempters, high risk, high lethality attempters, low lethality attempters. In your handout, you have some of that data. Today, I'm going to focus only on the prospective studies that we've done. That is, after following people 1 year, 2 years, 2 to 5 years, seeing what of these early risk factors actually predict suicidal behavior is more valuable to us than knowing what separates attempters and non-attempters based on past history. Because it tells the examining physician, the clinician, the psychologist, as they're looking at the patient in their office, it tells them what to look for to be concerned about suicidal behavior in the next year or in the next 2 years or 5 years. You have to understand some of the limitations involved in studying risk factors. Suicidal behavior is multi-determined. No one factor determines a suicidal outcome. There's a collection of factors involved. Risk factors vary over time. That is, what was a risk factor for a teenage girl is very different for a 30 or 40-year-old woman. There are some factors, and when you're looking at suicidal factors, there's some risk factors that are common across all diagnoses, like low socioeconomic status or poor education. I'm going to be emphasizing psychosocial adjustment, which to this audience should have a lot of meaning because it implies family relationships. People who have poor family relationships are at higher risk. People who have poor social supports are at higher risk. But that's a cross-diagnosis. It's not just for borderline patients. Some risk factors are more specific to given diagnoses. For example, command hallucinations are not found commonly in borderline patients, more commonly found in schizophrenic patients where they may be involved in suicidal behavior. And finally, we study attempters. Attempters are not completers. It's not the same group of people, but there's an enormous overlap. And the obvious is also true. Attempt statistically predicts reattempt and is a very strong predictor of completion. So these are not two completely separate groups. These are groups that merge into each other, and the more severe people who are attempters do go on to completion. Our job is to try to identify them and identify them when they're first seen in the office, to identify them early on. High lethality attempters do resemble completers. And again, I'm not going to go through that particular set of papers, but they are in your handout of the characteristics that separate high lethality borderline attempters from people who complete suicide. Now this is a sample, one of our samples. It's expanded beyond this point, but I want to show you the kinds of people that we are working with longitudinally. At present, their mean age is 28, so you have quite a ways to go. Keep in mind that Joel Paris's mean age at time of death for suicide was 37. So our folks are fairly young. Important to note here, most of them are in the lower socioeconomic status, 3 and 4. Our recruitment, we picked up about half of our subjects as inpatients, the others were outpatient or non-patients. 83% of them are attempters. They started attempting suicide on the average age 19. Fairly early, but again, there's a wide range. About half of them at time of initial intake met criteria for major depression, and 31% had dysthymic disorder. So a lot of affective disorder overlap. More than that, 64% had substance use disorder. Remember, this is at an initial intake. This is before we do our prospective longitudinal studies. So already these folks are involved with substance abuse, depressive. 22% had antisocial personality disorder, again, another vulnerability factor, which is highly predictive of suicidal behavior. Adverse childhoods, I mentioned that less than half actually have the abuse characteristic, which we made so much of in the literature. Now, I want to go ahead and show you what happens to this cohort when you follow them for 1 year. So we do the initial assessment. We see them once during the year, 3 months, and then 12 months later. So they put in 1 full year. And then we collect a wide variety of diagnostic tools. We've used a epidemiologic style analysis referred to as the Cox hazard, proportional hazard regression model, which essentially predicts the time. It shows you what factors are most predictive of the next time to a suicide attempt. So you end up with models that, taken together, highly predict people who are going to either have recent or attempts in the interval, or attempts or won't have attempts in the interval. So increasing or decreasing risk of suicidal behavior. And pretty straightforward findings. Comorbid major depression at baseline increases the risk of a suicide attempt in the 1 year interval. Poor social adjustment, as I alluded to earlier, also increases the risk. But any treatment in the interval decreases the risk. And here we had to do a little bit of careful analysis. That is that we took treatment only prior to any suicide attempt. We counted treatment for those who went on to attempt. We counted treatment experience only prior to that attempt. Because when someone has a major suicide attempt, they usually end up in hospital, and that counts as treatment by design. So treatment actually is controlled for pre-attempt. Any kind of pre-attempt treatment does diminish risk. Now, we went into that in detail. What kind of treatment? Well, at the level of we are now with only 137 subjects, we don't have a lot of power to do specific treatment types. But we were able to separate large groups. So we have people who are in outpatient treatment overall with diminished risks. Inpatient treatment, remember this is prior to any suicide attempt. Inpatient treatment increases risk. Well, again, we think that has to do with severity. The folks who are most severely impaired end up in the hospital. They're discharged, they attempt suicide. Medication makes no difference whether you're coming for medication visits. I shouldn't say medication makes no difference. Medication visits are not significantly predictive one way or the other. Again, this is very crude. Our outpatient category includes people with individual psychotherapy only, people with medication only, people with medication and psychotherapy, people in group, people in DBT, people in self-help groups. So we're going to need much larger samples to tease those apart. This is what it looks like if you put it in a curve, basically. Cumulative survival, everyone survives at the top. Down here, 88% have not attempted. So we're talking about small numbers as well, 19 attempters. From a clinician's point of view, that's pretty scary. I'm a clinician at heart. And when you tell me that that I'm going to have 19 subjects who attempt suicide within 1 year of an assessment, that's pretty scary to me. To a statistician, it doesn't mean much. They would like to see a lot more carnage to make a better graph. What you can get from this graph, basically, is that there's no one period of time that's more predictive of another in the first year. People attempt pretty much randomly along the whole year. Now, how many people made it to 2 years? Again, we're using baseline data. We've extended the time frame to 2 years. What predicts suicide attempts in 2 years? Or I should say more scientifically, predicts time to attempt in 2 years. An increased risk of attempt, again, there's a psychiatric hospitalization before the attempt. Any psychiatric hospitalization before a suicide attempt predicts the fact that the person is going to attempt after that hospitalization. And we, as I said earlier, we believe that's simply a severity dimension. Psychosocial adjustment again. Poor psychosocial adjustment predicts suicidal behavior. It's the second time we've seen it. We've seen it in the 1 year, we've seen it in the 2 year. The IPDE dimensional score, this is the International Personality Disorders Examination. This is just a severity measure for borderline patients. Now, earlier we saw a slide that had Dr. Gunderson's recent publication on poor outcome at 2-year follow-up for borderline patients. Our findings of suicidal behavior at 2 years are very similar to what John Gunderson was publishing for poor outcome. And of course that makes sense if you think about suicidal behavior as one of the markers of really bad outcome. But poor psychosocial adjustment and syndrome severity stand out. What happens when you extend the time frame, 2 to 5 years? Now here we did something that an epidemiologist would not do, but we do because we're interested in just that interval. We didn't use any baseline data to predict. We used the first data available at 2 years or later. So we re-examined everybody and used data only at 2 years or later. Forget about the baseline. We're looking at fresh factors here. We followed all these people 2 to 5 years, but we've used the first data in the interval. So what increases the risk of suicide? A low global assessment scale. Global assessment scale is essentially a measure, complex measure of symptom severity, of functionality. So poor functionality, more symptoms, increases risk. Childhood sexual abuse appears for the first time in any of our prospective hazards function studies. And what we're wondering now at 2 to 5 years is whether the liability or the vulnerability that's built into consequences of childhood sexual abuse have a long-term effect. They don't show up when the patient comes for treatment or when the patient is seen cross-sectionally. You see them in the emergency room, you see them in the office, you do your assessment. That's analogous to what we've done in research. Childhood sexual abuse appears to be a chronic vulnerability factor, which may show up more and more and more in longitudinal studies. So when you do a history, for example, a clinician seeing a patient in an emergency room gets that history, there's not a lot you can do about it. It's not one of the things that you focus on. You focus on depression, you focus on substance use, you focus on the current crisis at home, you focus on the family's support. This appears to be in the background. It's working as a vulnerability factor in the background. But we believe that as we look further and further out, that early childhood experiences are going to be markers for this long-term vulnerability. Earlier work that we published showed that people who had childhood sexual abuse had a 10-fold increase in the risk of having a suicide attempt, and they had more lifetime attempts. So over the long run, early developmental trauma appears to have more and more effect. Now, here was a bizarre find. That we found that people who had current major depression at the time of their assessment actually had less likelihood of having a suicide attempt in the interval. Doesn't make any sense. It's the opposite of what we found in the 1 year. So we looked at them more carefully. It turns out that most of them were in treatment. That by 2 to 5 years of follow-up, if you had major depression, you got yourself into treatment. And lo and behold, when we ran those statistics, we found that more patients in the 2 to 5 year follow-up had gotten involved in active treatment than people who were in our earlier follow-ups. So we believe that this is a paradoxical finding based on the fact that these people are now in treatment. Now, we will hopefully be able to follow these folks out even further and be able to identify the predictors of suicide attempt in the long run, especially those who go on to complete. This is what the curve looks like here. Again, I'm going to zoom ahead because I want to talk about lethality. How do we know who's going to complete suicide? No one's been able to find a magic formula. What we do know is that in patients who have multiple attempts, there's a very slow and very gradual increment in the lethality of their attempts. We use the Beck lethality scale. This is a crude 8-point scale which rates the medical consequences of the behavior from little effect up through death across 8 different kinds of suicidal behaviors. So a score of 4, for example, means that a person has been comatose because of an overdose. In the category of overdose, 4 means comatose. 1, on the other hand, is relatively trivial. Someone took a handful of vitamins and thought it was going to hurt them. Now, what you're seeing before you is a bar graph of medical lethality across numbers of suicide attempts. Individuals who had 6 suicide attempts had higher lethality scale score than individuals who had 1 suicide attempt. The numbers are different. These are done within group. So we had 136 people with only 1 suicide attempt, 19 people with 6 suicide attempts. And we did pairwise comparisons within group. Within group, these 19 ended up with higher lethality attempts than people with 1 attempt. Again, it's really, really gradual, and it's very subtle, and maybe in the next study it won't be significant, but at least it's the first inkling. In borderline personality disorder, the more often the person repeats, the more likely they are to have an increased lethality. This is another way of looking at it. This is a new kind of analysis called trajectory analysis, where the statistician is able to group individuals by the pattern of their behavior over time. So again, we're looking at lethality, and in this case, they included every single suicide behavior, even those with very low lethality, in this entire analysis. And again, you can see this factors into 2 groups. The best solution is 2 groups. One group starts off with a relatively low lethal effort for their first attempt, and they pretty much remain consistent across time. The second group, a little bit higher lethality on the first attempt, and very, very, very slow increment in lethality over time. We're up to 5 attempts here. So using this particular kind of statistical strategy, we hope to be able to identify characteristics of groups. As I mentioned, the trajectory analysis identifies groups. You can go within each group and say, what are the clinical characteristics of this group that separate them from the other? In other words, these are people who are likely to have increasing lethality over time. So in prospective analyses, we find that risk factors do change over time. Symptom severity and poor psychosocial and global functioning increase the risk in the short and the intermediate follow-up. An outpatient treatment may decrease this. For this group, in fact, I made this statement last time as well. I spoke with the NEA. Family support. That's what this is. Social support. I mean, this is a fancy way of measuring it. We use the Weissman adjustment scale, but it asks questions about family support, friends, jobs. Social support turns out to be equally important as syndrome severity in predicting suicide behavior. Okay, I mentioned that we have an interest in biology, the biology of impulsivity. So what about the biology? We've looked at 2 specific areas of suicide risk. One was the consequences of early childhood abuse, and the second is the impulse story, the impulsive depression as a risk factor for suicidality. Childhood abuse has received a lot of attention because of the association in adults with borderline personality disorder of brain structure changes, volume loss, predominantly in hippocampus and amygdala. The second strategy we use studies impulsivity, looking at serotonin receptors, in this case, the 5-HT2A receptor. And I'll preface my work explaining a little bit more about that as we get to it. So what's been done about structural imaging? As I mentioned several times, volume loss in BPD adults is found in the hippocampus, amygdala. It correlates with severity and duration of abuse in adults. But it's not been shown in adolescents who have been abused. So if any of you have access to children or adolescents with histories of abuse, this is a study really waiting to be done. Now, I mentioned because it's been touted a lot in adult borderline studies that abuse causes brain loss. Well, maybe it's not that simple. In addition, there's been volume loss in adults with borderline personality disorder, and reported in frontal lobes, orbitofrontal cortex, anterior cingulate, parietal cortex. A lot of areas, especially orbitofrontal cortex and anterior cingulate, that are involved with regulation of behavior. Dr. Hazlitt showed that impulsivity was inversely related to some of these volume losses in areas of the prefrontal cortex. Irritability and assaultiveness are related to some of the changes in white matter in the orbital prefrontal cortex. This area of the brain, the orbital prefrontal cortex, controls release of behavior. It's the inhibitory control center. It's where executive cognitive function is found. And we're talking about a fairly small part of the brain, right above the orbits, basically, where, think of it as the place in the brain where final decisions are made as to whether an affect will be released, as to whether an impulse will be released, or to whether it will be inhibited. One of my students referred to it as the Dr. No of the brain. It's the final arbiter of what gets out. So it's responsible for inhibition. And we look at the orbital prefrontal cortex and its connections because borderline patients are individuals who are disinhibited. Now, structural, but very quick lesson in how you measure the brain. There are two popular structural methods these days. The gold standard are the hand-drawn regions of interest. That is, they look at slides of the anatomy of the brain projected onto a computer, and using a special pen, you outline the area of the brain defined by specific anatomical markers. So I mentioned the orbitofrontal cortex. There's specific anatomical markers for it. The technician looks at the slide, draws circles around it using those, and the volume therein is calculated. It's very labor-intensive, but it's the gold standard. And this is a typical study, happens to be one of ours. Dr. Brambilla published this in 2004, showing that hippocampal volumes in adults with borderline personality disorder are diminished. If you look here, you look at the right side, healthy controls up here, borderline patients down here. Left side, same finding, statistically significant, small numbers, but it's compatible with everything that everyone else has shown in this area. Primarily loss of hippocampal volume in borderline patients. Dr. Brambilla did an analysis of a smaller cohort of these folks to show that the same is true if you look at those individuals who had histories of abuse. That is, small hippocampal volumes in abused subjects compared to non-abused borderline subjects. The second method is relatively new. It uses the same method that PET scanning uses. It's based on comparing voxels and computer pictures using a technique called statistical parametric mapping. Basically, it looks at areas of activation in the entire brain, as opposed to having to look at a specific piece of the brain. Doesn't require any a priori definitions. When you're doing a manual ROI project, you have to really have a priori hypotheses because it's so labor intensive to look at any one area of the brain. You can't afford to look at everything. You don't require that in voxel-based morphometry. It's not as precise, so think of it as a screening method. And we did a BBM study on 24 borderline patients, 30 healthy controls. That's a modest sample size for this kind of work. Typically, these researchers like to have 60. So 34-30 is modest. And then we did subsamples. First we did all of our borderline patients, all of our healthy controls, and then we looked at females only. 22 borderline females, 19 healthy controls. And then we looked at those females who endorsed a history of childhood sexual abuse versus non-abuse. So the numbers get smaller and smaller as we go down. What we found first is that there was significant reduction in the gray matter concentration in the cortex in borderline patients. This is the ventromedial part of the frontal gyrus. Again, it's very close to the part of the brain, the ventromedial and orbitofrontal parts of the brain which are involved in this executive function of inhibition. So there's a loss in gray matter concentration in borderline patients compared to controls. I'll show you what these other areas are in the next slide. These are areas around the medial temporal cortex. They overlap parahippocampus, fungus, and the amygdala because of the methodologic differences between this kind of study and the morphometric study. There is a distortion introduced which moves us anteriorly, so we miss the hippocampus. We got the parahippocampal gyrus, the amygdala, and the uncus, which again are diminished in concentration as far as the gray matter is concerned, correlating with diminished volume in a morphometric study. They use different words in this kind of analysis. But again, there's loss in borderline patients compared to controls. Loss of gray matter, adult borderline patients. And finally, well, here we did these are the female patients, the same finding, with the less robust, going down in numbers, but exactly the same areas. So the finding is still there in female borderline patients compared to female controls. Loss of brain matter in the brain. And the least robust, but still demonstrable and significant, is in the few borderline patients that we had with histories of sexual abuse, that is 8 compared to non-abused and borderline females. Again, all borderline patients here, all borderline patients, abused versus non-abused. And again, there's a volume loss, a significant volume loss of medial temporal lobe in these folks. Now, I mentioned that the second series of studies that we've been doing looks at serotonergic neurochemistry. It's been shown and known for a long time that diminished serotonergic regulation, measured by various means, whether spinal fluid or fan challenges, diminished serotonergic regulation is associated with increased impulsivity, increased aggression, increased suicidal behavior, increased lethality of suicidal behavior. We did some earlier PET studies where we showed by giving fenfluramine in the PET scanner, we showed that there was diminished activity in prefrontal cortex of borderline patients who were suicidal and impulsive. And again, that's part of the story that has emerged over the past 10 years, that this part of the brain, this neurochemistry, serotonergic neurochemistry, has to do with regulation of impulse and impulsive behavior. And there's something wrong in borderline patients in that area of the brain, in the serotonergic regulation of impulsivity and aggression. And that acts as a chronic vulnerability. So when other things occur, like depression, or abandonment, or abuse, or loss, these folks are more likely to act on impulse and become suicidal. So in this particular set of studies, we've started looking at the specific receptors involved. The 5-HT2A receptor has been shown to be upregulated. There's an increased numbers of it in the ventrolateral and orbitofrontal cortex. This is Dr. John Mann's work, Dr. Vicky Orange. They're at the Columbia University of New York. Very, very elaborate and detailed work demonstrating that there is in people who have committed suicide, these are in autopsy specimens, that there is an upregulation, increased numbers of these receptors, 5-HT2A receptors specifically, which implies whenever you have an upregulation, the theory is that there's been too little serotonergic stimulation. So decreased amount of serotonin, increase in the number of these receptors. So you're looking at, we believe, the theory is, we're looking at the consequences of diminished serotonergic innervation. Okay, so we looked at the binding of 18-methyltanserin, which is an antagonist of the 5-HT2A receptor. It sits on the 5-HT2 receptor, we can measure it. And what we would like to see, what we expected to see, we expected to see increased binding in people with suicidal behavior, increased binding in borderline patients. We expected to see increased binding specifically in the frontal cortex. Increased binding would mean decreased serotonin. It would go along with the autopsy data. Instead, we looked at 19 borderline patients, 21 control subjects. When we had all of our data pooled across our areas of the brain, these are different areas of the brain, anterior cingulate, hippocampus, orbital frontal, medial frontal cortex, et cetera, different areas of the brain. When we looked at different areas of the brain, we didn't find anything different. These are not statistically significantly different. But we did find interactions between gender and our results. So that was an indication we had to look at boys and girls separately. When you do that, only one strong significant finding shows up. I'm not going to show the trends, but the strong significant finding is in an area we never thought to look in serotonin studies, and that is in the hippocampus. And what this says is that female borderlines have increased binding in the hippocampus compared to males. Increased binding, again, suggests decreased serotonergic transmission in that area of the brain. This is not an area that we normally look when we study serotonin. We normally look at the prefrontal cortex. And I mentioned I wasn't going to show the trends because the trends are in that area. But still, they're not statistically significant. And this appears to be a fairly robust finding. Small numbers, but we've tried to knock this finding out using a variety of methods. We factored out the volume of the brain. We factored out the volume of the hippocampus. We looked at all kinds of technical tricks, blood flow. It's a robust finding for this sample size. So now we've got a puzzle. Well, what happens when you look at boys? Even smaller numbers, and again, I take this with a grain of salt because we're talking about really small numbers. 5 male borderline patients. And again, lots of significant findings you didn't see in the females, but look at the direction. It's in the opposite direction. There is, in the borderline males, the direction is not increased, but decreased. Increased binding means decreased serotonin. We have decreased binding in the males. That would imply, if you think that theory makes sense, that you have increased serotonergic transmission in this area of the brain in male borderlines. I don't have an explanation for that. It's across the board. It's across the board. Decreased binding in males. We don't have an explanation. That would imply increased serotonergic agonism. Now, what happens when you look at control subjects? Okay? It turns out that boys and girls are different. Normal boys and girls. So when we looked at healthy females and healthy males, again we find differences. We find that healthy females have decreased binding in the hippocampus, decreased binding across the board compared to healthy males. And yet these people are not symptomatic in any way. They have no axis 1 or axis 2 disorders, no suicidality, no increased aggression. What this implies is that the serotonergic system is gender specific. And there are lots of other examples in basic science where parameters of the serotonergic system is different in boys and girls. Why would that be important? Well, it suggests that aggression, impulsivity, and in my case, looking at suicidality, may be mediated by different mechanisms, different biologic mechanisms in males and females. If normal males and females have big differences, these are statistically significant, big differences in the way the serotonergic system works in these areas of the brain, perhaps what we're looking at in borderline patients is an exaggeration. But we have to begin to understand, or try to understand, what are the clinical implications of differences in serotonergic neurochemistry in males and females, normal males and females. They clearly have a different neurochemistry and perhaps different biochemical mechanisms for handling aggression and impulsivity. I like to present these because I don't have any answers. I have questions. This is only the second time this data has ever been presented. So if people have some good ideas for me, I'd be more than receptive. Thank you very much.